بسم الله الرحمن الرحيم الحمد لله رب العالمين والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه وسلم أجمعين. سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. اللهم علمنا ما ينفعنا وانفعنا بما علمتنا يا كريم. Dear colleagues, we'll continue the topic of intensive care radiology. You remember from the first part we have some obstacles by the end of the lecture, and we stopped at the talk about the pulmonary artery catheters or the Swan-Gang catheter, and I show you some of the videos showing the components of the catheter, and I mentioned the indications of the insertion and the accurate or the optimal position for the tip of the catheter, which should be about 2 centimeter in the range of 2 centimeter in the from the hilar shadow. Then the balloon tip is inflated when measurements are being obtained. And the occlusion of the pulmonary artery branch, you remember, can also result in pulmonary infarction if the catheter is pushed to distal, or if there is persistent inflation of the balloon, or if a clot is formed around the distal tip of the balloon. And this is an example of a Swan-Ganz catheter, which is inserted somewhat distal to the optimal position. The tip of the catheter needs to be a little bit withdrawn to be in the range of 2 centimeter. The tip should be in the range of 2 centimeter from the hilar shadow. Then the endotracheal tube is positioned well above the carina, while the nasogastric tube is seen in the esophagus and it needs to be repositioned. Also, you can notice in the chest X-ray some area of ill-defined consolidation in the left lower lung lobe. This is the arrow points to the tip of the Swan-Ganz catheter, which is located in an almost optimal position. And this video may show to you how the catheter is inserted.
For this type of central line, I'm going to float a pulmonary artery catheter. So I'm going to need a type of central catheter that has an introducer port. Right there and right there. So I've already found the IJ with my finder needle, so I'm just going to go in through that same spot. Hold negative pressure here. Always make sure that you're occluding any kind of catheter directly into the vein so it's not open. So now I hook up my tubing here and I raise it up. And that looks venous to me. If it were arterial, this blood would be coming up. One last thing that you can do to really make sure that this is truly venous is to transduce the waveform, and you need someone that's, you need an assistant to be able to do that. So I'm going to hand that to you and go ahead and hook it up to our transducer and we'll look at the pressure. Pressure's good, so this thing is venous. I can now take this off. So I take that off. Go ahead and get rid of that for me. Now that this wire is back in, it's time to float our central catheter. So I'm going to load my cordis here with the dilator. And then when it gets to right here, there's a couple of points that I want to make. Number one, you should never insert this central line in until you've grabbed the wire on the opposite side, okay? Number two is this is going to meet a lot of resistance there at the skin, so you're going to need to make a small nick with the scalpel. Now that line is in, so now I can remove the dilator and the Seldinger wire. Alright, once that's in, I'm going to need my assistant to flush this line for me and hook up fluids. So that part's no longer sterile, I can't touch that anymore. Okay, so now that's not sterile anymore, so I'm just going to cover it with this blue drape. Okay, now that that's sewn into place, it's time to float our swan, so I need an assistant here to help me. And, man, I'm going to give this to you. That's yours. Now, while he's taking care of that stuff, I'm just going to put this sterile cover over the swan.
Alright, so I'm going to hook up this syringe to the balloon port, the red port right here. Now I'm going to hook up this saline to the white port. Now I'm going to hook up my CVP tubing to the blue port. And then I'm going to hook up my PA tubing to this yellow port here.
Alright, brother, let's test the balloon. Balloon up. Okay, balloon's good. Deflate the balloon. Okay, go ahead and flush my white port, please. And I can see that it's flushed. Okay, so now that that's flushed, go ahead and hook up my infusions.
My infusion tubing here to the stopcock.
I'll open the stopcock. Okay, now go ahead and flush my CVP, please. Okay, looks good. Go ahead and flush PA. Okay, looks good. We're ready to float this thing. Let's do it. Okay, so just ready to float this now. Why don't you go ahead and inflate the balloon for me?
Balloon is now up.
Okay, so now we're going to look at our pressure waveform to guide where this is as we advance. Okay, so right now you can see him in the right atrium. So I'm just going to advance here slowly. Watch for waveform changes. Alright, looks like I'm in right ventricle now, so I'm going to keep advancing. Okay, that looks like PA because my diastolic pressure went up. And it looks like I've wedged right there. I'm going to stop right there. Okay, so once that's floated, I'm going to put that cap on. We're ready to go. I can take this drape off. Alright, now I'll take a sterile opsite, please. Just prevent infection. There we go. We're ready to go.
Okay, we have seen how to introduce the Swan-Ganz catheter, and you noticed that the position of the catheter is judged by the electrocardiogram, and you do not need to go to the radiology department to look at the catheter under fluoroscopic control. And this is also a short video to show you how can they control the catheter using the electrocardiogram, and it will show also the flow of the catheter or the pathway of the catheters through the superior vena cava and in the right atrium. Then you see that the balloon is inflated and the ECG monitor is judging the position of the catheter when it is in the pulmonary artery. Then if you go to the wedge size and site, then you may inflate the balloon and impact the balloon in the pulmonary artery to get the accurate measurements. You see how can you judge the position of the catheter through the electrocardiogram. Now, the complications of the cathetering are almost similar to any central venous line insertion, like catheter misplacement, looping, coiling, or knotting, pneumothorax, and vascular injury. These are rare complications, but they are usually fatal, like the uncontained pulmonary artery rupture or dissection of the pulmonary artery with without the formation, with or without the formation of pseudoaneurysm, or if the balloon ruptures with development of fistula between the pulmonary artery and the bronchial arteries. In this patient, the Swan-Ganz catheter is seen in the right ventricle. It needs to be advanced until it reaches the optimal site, as we mentioned. And here you can see the Swan-Ganz catheter with its tip almost in an accurate position. Also, you can see the endotracheal tube well positioned proximal to the site of the carina. And here you see an central venous line which is located in the internal jugular vein, another central venous line which is crossing to the through the innominate vein to the superior vena cava. And this patient, you see the Swan-Ganz catheter, which is located in the pulmonary artery, and then is advanced in the left main pulmonary artery. You see some veiling opacities, especially in the left lung, and also you can feel that there is some pleural fluid. Then the Swan-Ganz catheter has been withdrawn into the superior vena cava, but the opacities are still there and the effusion is also present. And you actually noted that the patient had a previous open heart surgery. And these are mediastinal drains that has been removed in this follow-up chest radiograph. Then we come to the cardiac pacemaker, which is the last in the tubes that should be evaluated in an ICU patient. These pacemakers are temporary and also may be permanent for treating a variety of conduction abnormalities in the heart. Intravenous placement of the cardiac pacemaker is preferred in ICU unit and is usually introduced through the internal jugular or the subclavian vein. Pacemakers are composed of a pulse generator and also the lead wires with electrodes for getting in contact with the endocardium or the myocardium. Different pacemakers are available, including single lead and complex devices with multiple leads. Typical pacemaker electrodes are usually placed in the right atrium and the right ventricle, but sometimes we may have a biventricular pacing and also left ventricular pacing is added through the coronary sinus to stimulate the left ventricular myocardium. This is a video that will show you how the pacemaker is inserted.
A surgeon will insert a pacemaker into your body if your heart's conduction system, the electrical system that makes your heart beat, is not working properly. The heart is a muscular organ with 4 chambers. Blood collects in the heart's 2 upper chambers, or atria, before filling the 2 lower chambers, or ventricles. When the ventricles contract, blood in the right ventricle is pumped to the lungs and blood in the left ventricle is pumped to the rest of the body. The heart has a natural pacemaker called the sinoatrial node, or SA node. The pacemaker controls the heart rate by precisely determining when the muscles of the atria and ventricles contract. The electrical signal produced by the SA node reaches the ventricles through a narrow pathway that includes the so-called AV node and bundle branches. Taken together, these pathways are referred to as the conduction system of the heart. Problems with the conduction system can result if the SA node malfunctions, causing the heart to beat too fast, too slow, or irregularly. Alternatively, a blockage in the bundle branches can develop, causing the heart to beat more slowly or irregularly. These problems can be due to heart disease, medications, or cardiac surgery. Before the procedure, your blood and urine will be tested. You will also have X-rays taken of your chest, and an electrocardiogram, or EKG, will record the electrical activity in your heart. A local anesthetic will be injected into your skin to numb the area where the pacemaker will be inserted. The surgeon will make a small incision beneath your collarbone. The pacemaker's leads will be inserted into the subclavian vein and then threaded toward your heart until they reach the right atrium. Your surgeon will view X-ray images on a video screen to position the leads correctly. Once the leads have been tested, they will be connected to the pulse generator. The pulse generator will then be placed in a small pouch that your surgeon will create under the skin beneath your collarbone. Your surgeon will then sew the incision back together. While you're in the hospital, your doctor will monitor your heart rate and blood pressure to be certain the pacemaker is working properly. Before you leave, he or she will make final adjustments to the pacemaker settings. After your procedure, over-the-counter pain medications such as acetaminophen or ibuprofen should be sufficient to relieve any pain. You will not be able to drive for about 2 weeks. Periodically, you will need to follow up with your doctor to test and adjust your new pacemaker.
Okay, then you have an idea about the work of the pacemaker and how it is inserted. And this is the chest radiograph after insertion of a dual pacemaker. You can see one of the leads is in the right atrium and the other lead is in the right ventricle, and also is clearly seen in the lateral view. This is a pacemaker with 3 leads. You got the regular leads in the right atrium and in the right ventricle, and also you got the 3rd lead in the left ventricle. And here you can see another cardiac pacemaker with more than 2 leads, and you see the insertion of the leads in different cardiac chambers. Now you know, I think that you know that there is
You'd never know by looking at
what is
Nellie the
known
Joy
as
on her fairway
wireless
that she's part of
pacemaker,
medical history.
and
See you in a couple of weeks.
wireless
But one day
pacemaker
before this visit with her doctor, she became the first person in the state of
is
Kansas and the
can
region
avoid
to
some
receive
of
a
the
revolutionary
complications
kind of
of
pacemaker for her heart.
the
It's the
wire
smallest one ever
pacing.
made. And best of all, it has no leads like a traditional pacemaker. Doctors at the University of Kansas Hospital implanted the device in a simple, non-surgical procedure that eliminates the risks that can come with a traditional pacemaker. Those traditional devices require the doctor to make a surgical incision in the chest where the pacemaker permanently sits in a pocket under the skin. The leads from the device go through the veins into the heart, delivering the electrical pulses that keep the heart beating at a normal rate. The new device eliminates all that by combining the pulse generator on the end attached to the heart with the battery on the other end, all in one miniature device. Here's how it works. Doctors run the device through an artery in the patient's leg up to the inside of the heart. Once it's in the right position, the doctor, with the help of a special tool, removes the protective cover It actually screws the tiny device right into the inside wall of the heart. Dr. D.J. Laccaretti is the electrophysiologist who implanted this first device, part of a clinical trial, and he says the advantages for patients are tremendous.
This is definitely the way of the future. Patients don't have pain in the chest, risk of infection goes down dramatically, risk of lung puncture, and all those go down significantly. And patient ambulates much faster, so there are no limitations in their arms, not going up and down, stretching the arms by mistake, and all those things do not exist. So the overall patient comfort is unbelievable. The longevity of the device is much better.
Patients also don't require nearly as much anesthesia, which means they're up and around much quicker. Just like Barbara Moore of Leawood, who was the second patient to receive this new pacemaker. Less than 24 hours after her procedure, she was ready to go home, telling her doctors how great she felt and talking about resuming a lifestyle she thought she'd have to give up.
I have been a very active person in the past. I like to hike in the mountains. I exercise a lot, and all that was over. I couldn't do any of that anymore, even going up a flight of stairs.
Okay. And sometimes you have a patient who needs that another pacemaker which is used to stimulate the brain and is known as deep brain stimulator. And in such cases, you should fix the generator of the brain in a chest wall and the pacemaker on another on the other side of the chest wall in order to avoid interference between both pacemakers. And the complications of pacemakers include the development of pneumothorax or vascular injury during insertion. Myocardial perforation is uncommon, but it usually occurs in the right ventricle. Perforation may lead to pericardial effusion and even cardiac tamponade. Leads of the pacemaker may fracture, and the incidence is about 1 to 4%. Lead fractures commonly occur between the clavicle and the first rib. And you can see here there is a kink of the leads at the level of the clavicle and the first rib. And this is a patient with a pacemaker who is suspected to have a small apical left pneumothorax. Then an inspiratory and expiratory films confirm the presence of a small pneumothorax in the left apex, and you can see the apex is devoid of vascular markings compared to the opposite side. But this is a large pneumothorax complicating the pacemaker with almost subtotal collapse of the right lung. Here, an example that suggests myocardial perforation, since you see that the tip of the lead is beyond the cardiac shadow, and actually it may perforate the myocardium. And one of the complications also is the erosion and the externalization of the pacemaker generator from the skin, and there are usually, like you see here, there are some of the predisposing factors like an extremely fragile skin of elderly patient, a small socket for the battery, and a scanty subcutaneous fat, the chronic use of corticosteroids or the abrasive disinfectants. Now we came to the second part of the ICU radiology, which will deal with the pulmonary parenchymal lesions, including these pathologies, as well as some talks about the pleural lesions and also mediastinal pathology. Pulmonary parenchymal lesions in ICU patients include atelectasis, aspiration pneumonia, pulmonary edema, acute respiratory distress syndrome, pulmonary embolism, lung abscess, and the barotrauma. And OPA and Zaza in 2009 concluded or found that there were no increased adverse outcomes in patients who did not undergo routine daily chest radiograph versus patients who did these radiographs. But actually, there are, as I have mentioned before, some real indications to do a chest radiograph in let's say, a regular way to check for some of the devices and see the complication of insertion of the tubes. An atelectasis means a collapse of a part of the lung, and if the whole lobe is collapsed, then you call this lobar atelectasis, but lobar collapse. But atelectasis is usually given to a subsegmental area that has been lost its volume. There are many types of atelectasis, include the gravity-dependent type, obstructive type, passive, compressive, adhesive, and cicatricial type. The adhesive atelectasis is usually secondary to decreased surfactant and is commonly seen in acute respiratory distress syndromes as well as in premature neonates. The cicatricial atelectasis is usually the sequelae of fibrosis and is not seen de novo in ICU patients. It's a long-standing disease or pathology. The common sites of atelectasis are in the left lower lobe, the most common one. If you look here and you can see a triangular opacity behind the cardiac shadow, and this is left lower lobe collapse. And the right lower lobe is less frequent, and the right upper lobe is more or less frequent. And atelectasis is usually subsegmental, but it may affect one of the lung lobes. The signs, the radiographic signs of atelectasis include displacement of the fissure, crowding of the vascular marking and bronchi, and there may be a small pleural effusion associated with atelectasis, or atelectasis itself may simulate a small pleural effusion. This is right lower lobe collapse. You see the opacity which is confined to the lower lobe with displacement of the minor fissure lower down. In subsegmental atelectasis in the right lung, you can see that atelectasis may contain air bronchogram and may not contain air bronchogram. There are two thick bands of atelectasis in both lower lung lobes. They are suspected to be due to pulmonary emboli, but the CT scan showed no filling defects in the emboli and showed the atelectatic bands in the lower lobes. And here you can see a left lower lobe area of consolidation in the lateral view, which is not commonly available in the ICU unit. You got this opacities confined to the lower lobe. There is some displacement of the fissures, but the lobe is not totally collapsed. Then you call this middle lobe consolidation, which may simulate atelectasis. Then if you have the CT scan, it will show the compression and atelectasis of the lower lobes because of the pleural effusion in this case. And whenever you inject contrast material, according to the literature, you can differentiate atelectasis from consolidation, since atelectasis should enhance greater than the skeletal muscle, while consolidation will enhance either similar or less than the skeletal muscle. And if you look here, and this is a pleural effusion with underlying atelectasis showing significant contrast enhancement. But on the opposite side, you can differentiate between atelectasis and consolidation, which is not enhancing, suspecting the possibility of necrotizing pneumonia. And aspiration is commonly seen in the critically ill patients and is also increased in incidence in patients with a decreased conscious level. Aspiration may result in pneumonitis, or pneumonia or aspiration of inert non-toxic substance. Pneumonitis do not usually require treatment. It regresses and resolves spontaneously, while pneumonia needs treatment by antibiotics. And severe aspiration event can lead to acute respiratory failure, sepsis, or acute respiratory distress. In patients who are intubated, they can also aspirate in spite of the presence of the endotracheal tube with inflated cuff. Then aspiration and the incidence of aspiration pneumonia in the ICU unit is about 5 to 15 percent of the all community acquired pneumonia. The risk factors for aspiration and aspiration pneumonia include obesity, old age, diseases in the teeth, neurological disorders, altered conscious level, functional dependence on the activities of daily life, and various gastrointestinal conditions. And you see here a female patient, 80 years old, with aspiration pneumonia on the right side. The follow-up chest X-ray showed some clearance of the pneumonia in the right lung base, with development of another left lower lobe aspiration pneumonia, and the third follow-up done after that showed almost total clearance of the two aspiration events. And this is the aspiration pneumonia in the left lower lobe, an area of consolidation showing air bronchogram. The chest radiograph may be normal in about 10% of cases with aspiration pneumonia, and the aspiration may manifest as focal or multifocal pathology. Also, the CT scan can show the classic appearance of what's known as the tree-on-bud opacities. The aspiration pneumonia may be associated with volume loss of the affected part of the lung, and pneumonitis may progress in the first day but clears within few days, while progression of consolidation and symptoms suggests the development of pneumonia. And in a recumbent patient, pneumonia aspiration usually occurs in the dependent parts, including the posterior segments of the upper lobes, the superior segments of the lower lobes, and then the posterior basal segments of the lower lobe. Sometimes aspiration pneumonia is complicated by lung abscess, and CT, of course, is more sensitive than the chest X-ray to see these complications. And here you can see a patchy opacity in the right upper lobe and also the apex of the left lower lobe. CT scan showed the consolidation with air bronchogram as well as the aspirated debris within the right main stem bronchus. This is the classic appearance of aspiration with tree-on-bud. This is the most classic appearance of, in the CT scan, showing describing the tree-on-bud opacities. They are not clearly demonstrated in the plain film, but can be seen in the CT scan. And pneumonia, we have to mention some of the definitions, like community-acquired pneumonia, which is pneumonia in patients admitted from home, and it develops within the first 48 hours of hospital admission. This is known as community-acquired pneumonia. Then you have what's known as healthcare-associated pneumonia, and this is pneumonia developed in a hospitalized patient receiving treatment within 30 days. And nosocomial pneumonia develops 48 hours after admission, commonly seen in ICU patients. And nosocomial pneumonia in ventilated patients is known as ventilator-associated pneumonia. The incidence of this type of pneumonia is about 7% in ICU patients. And here is the male patient, 30 years old, presenting with the pneumonic consolidation in the right lung. And if you look carefully, you can see a starting development of cavity in the mnemonic badge, and also you can see some blunting of the costophrenic angle denoting the development of a small pleural effusion. In this example, you can see consolidation of in the right lower lung zone that is projected in the lateral view within the middle lobe. In patchy areas of consolidation with air bronchogram are helpful to diagnose pneumonia from other conditions in the lung, but you remember that I have mentioned that atelectasis can also show air bronchogram. Mnemonic air bronchogram is not associated with volume loss like that with atelectasis. Cavitation is a more specific sign of pneumonia. In Pneumonia is commonly present in patients with acute respiratory distress syndrome. The chest X-ray is only 60% accurate in differentiating pneumonia from non-pneumonic opacities in the lung. And CT can show complications of pneumonia like abscesses and effusions. Contrast enhanced CT can differentiate between pneumonia and atelectasis based on the enhancement, as I have mentioned before. Then hypoenhancement is a sign of necrotizing pneumonia. And you see multifocal pneumonia in the left lower lung lobe as well as in the right upper lung lobe. There are two areas of consolidation with no evident air bronchogram. And here you see some veiling opacity in the left lower lung zone. You can see that the cardiac border is well defined through the opacity, denoting that the opacity is located posteriorly in the lower lobe, and this is left lower lobe consolidation. And you see some blunting of the costophrenic angle with possible development of effusion. In this example, there is an opacity that is related to the right cardiac border, which is masked by the opacity, denoting that the opacity is anteriorly located and indicating the middle lobe consolidation. Here you can see an opacity in the right upper lobe with some loss of volume, elevation of the horizontal fissure, and air bronchogram, and this is upper lobe consolidation. And you may see the distension of the gastric fundus underneath the left diaphragmatic copula. And this patient here is consolidation of the right upper lobe and atelectasis in both lower lobes. In the left side, there is a significant elevation of the diaphragm and indicating some loss of volume in this particular case. And this consolidation was proved to be due to an pulmonary infarction, and later on it has been cavitated, resulting in a lung abscess. And actually, pneumonia may cavitate into a lung abscess, and this can be well demonstrated by CT, as you can see here. And it's worth to mention that organisms that can cause lung necrosis resulting in cavities are the Staph aureus, Klebsiella, pneumococcus, and the TB. And this patient, you can see an opacity in the left lung, and this opacity has been progressed and to obliterate the whole left hemithorax, and he should at that time suspect that there should be a pleural disease associated with this pneumonic consolidation. And whenever you have the CT scan and you can see a pleural empyema compressing the left lung with enhancement of the pleural surfaces, denoting an associated infection. And also, here is an example of an abscess complicating pneumonia. You can see the pneumonic consolidation, then central breakdown, then actual development of an abscess. And after therapy, you got too much clearance of the disease. This CT scan at the phase of lung abscess formation clearly demonstrate the cavity with internal air loculi. Then we came to the pulmonary edema, and this is a common cause for admission to ICU. And you have two types of pulmonary edema, the hydrostatic edema and the permeability edema. Worth to mention that the two entities may coexist and may complicate the interpretation. Actually, whenever you are looking to the hydrostatic edema, which is the sequelae of congestive heart failure, and you see some of the previously mentioned signs like haziness of the hilar shadows, distension of the upper lobe vessels, increased interstitial lung markings, the development of B and A curls lines, and maybe sometimes you can see pleural effusion either on the right side or on both sides. Then the hydrostatic pulmonary edema is the sequelae of pulmonary venous hypertension and seen in patients with left-sided failure, heart failure, or renal failure, or in cases of hypovolemia. These are the classic appearances, as I have mentioned before. The changes are usually bilateral and symmetric, and you got enlargement of the vascular pedicle, pulmonary vascular congestion with distension of the upper lobe vessels, subpleural interstitial edema with development of too many interstitial opacities, including the B and A curls line, ground glass opacities, and sometimes we got consolidative opacities denoting the development of pneumonia. Hydrostatic pulmonary edema is the cardiogenic edema where you can see the consolidation is dependent, cardiomegaly is present, pleural effusion may be bilateral, and if unilateral, it will be on the right side. While non-cardiogenic pulmonary edema consolidation is diffuse, septal lines are not common, and the heart size is within normal. In this patient with non-cardiogenic pulmonary edema, he has intracranial hemorrhage with hydrocephalus. Then you got two alveolar opacities on either side of the heart. And according to the literature, the differential of these opacities will include edema, infection, and pulmonary hemorrhage. And because the clinical history of the patient and the absence of septic markers in the patient can suggest the possibility of non-cardiogenic pulmonary edema. This is acute pulmonary interstitial edema with bilateral ground glass opacities, interstitial septal thickening with A and B curls lines. If you use CT, you can see ground glass opacities with thickening of the pulmonary interstitium. You can get bilateral pleural effusion as well as ground glass opacities. This patient with cardiac arrest showed bilateral areas of consolidation, and he can elicit some air bronchogram. The coronal reformatted CT images clearly demonstrated the central position of the opacities, indicating that the opacities are due to pulmonary edema. Another case of non-cardiogenic pulmonary edema showing extensive pulmonary opacities seen well in the X-ray as well as in the CT scan. High altitude is also one of the causes of pulmonary non-cardiogenic edema. You can see the opacities on both sides, and this is another cause of what is known as near-drowning pulmonary edema. You can see extensive pulmonary opacities in both lung fields, and on the CT scan, you can see extensive ground glass veiling of the pulmonary parenchyma on both sides. Then the permeability pulmonary edema or the non-cardiogenic pulmonary edema is presented by extensive bilateral airspace opacities, and the opacities may be progressed to involve the whole of both lung fields. The distribution of the opacities is usually asymmetric and patchy. The air bronchogram is commonly seen. Septal lines are not common. The vascular pedicle, the heart size, the pulmonary vasculature are usually normal. These are the causes of non-cardiogenic edema, and you can remember by this word. It's not cardiac, near drowning, oxygen therapy, transfusion-related acute lung injury, CNS or neurogenic abnormalities, alveolar alveolitis, renal failure, drugs, inhaled toxins, altitude, and pulmonary contusion. The acute respiratory distress syndrome is one of the examples of permeability edema secondary to diffuse lung injury and alveolar damage. This ARDS can affect any age group, and the patients are usually intubated because of the severe respiratory distress. The high-resolution CT findings will show patchy ground glass opacities or areas of consolidation, and the opacities are usually in dependent lung regions. The ARDS associated with high mortality as much as 50% and is commonly seen in ICU patients. These are the predisposing conditions, which are almost similar to the previously mentioned one under the title of not cardiac. In the imaging findings, you cannot see enlargement of the cardiac shadow. There, there is no pleural effusion, no careless line, and there may be evident bronchogram. The lesions will appear in the lung with a latent period of, let us say, 12 hours after the insult. Then between 12 and 24 hours, patchy alveolar infiltrates are seen. Up to 48 hours, massive airspace consolidation of both lungs. Within 5 to 7 days, there is some clearance of the opacities, which is attributed to ventilation rather than through healing. And if the disease has progressed, it will lead to pulmonary fibrosis. Commonly, the disease it may be complicated by pneumonia, and this is judged from the radiographs by the development of new areas of opacities and the development of pleural effusion. And continuous positive airway pressure, or the CPAP, may be complicated by pneumothorax, pneumomediastinum, or pulmonary interstitial edema. Then barotrauma means that abnormal air is collecting in the chest, which may occur in the lung, may occur in the pleura, or in the mediastinum. And about 5 to 15% of the ventilated patients may develop barotrauma. And lung disease like pneumonia, especially ARDS, have a high risk of development of barotrauma. The effect of barotrauma is more severe in children and adults, young adults up to the age of 40. And the initial collection of air will be within the lung, resulting in interstitial emphysema. Then gas collects into the pleural spaces and also in the mediastinum. Pulmonary interstitial edema carries a significant risk of pneumothorax in about 77% of the cases. Pneumothorax is the most common concerning sequelae of barotrauma. Is seen in about 25% of ventilated patients. Pneumothorax may be associated with pneumomediastinum. If pneumothorax is not seen in the supine chest radiograph, then you may try to have the upright position, the expiratory or inspiratory films, or the decubitus position, and maybe if you can, you have the CT scan, which is more sensitive. Then you may got false impression about the presence of pneumothorax due to skin folds, overlying tubes, and the prior chest tube tracts. Then how can you judge the presence of pneumothorax, particularly in the supine position, which is the frequent position of the patient in ICU? A small pneumothorax can enlarge due to ventilation, and it may result in tension pneumothorax, which is present in up to 95% of ventilated pneumothorax cases. And that's to say, if the patient developed pneumothorax and is on ventilation, he may develop tension pneumothorax. And you know, the basic radiographic signs of tension pneumothorax is the presence of mediastinal shift and the depression of the diaphragm. And according to the literature, mediastinal shift may not always be present. But other signs include displacement of the anterior junction line and displacement of the zygoesophageal recess, flattening of the heart, and the vascular shadow. Pneumomediastinum is important as the general sign of barotrauma, and it can have its own radiographic signs I will mention. Here you can see there is bilateral opacities in the lung, but if you look carefully, you can see some air tracking along the mediastinal border, and you can see the clear definition of the diaphragmatic copulae on both sides, which is an indication of the presence of bilateral pneumothorax. If you look here, you can hardly see the pleural line indicating the presence of minor pneumothorax in the apex of the left lung. And here is the diagram demonstrating the pleural line, is the area of pneumothorax, and the somewhat, let's say, flattening of the diaphragm. Also, remember the deep sulcus sign, which is one of the good signs to judge the presence of pneumothorax in the supine chest radiograph. The deep sulcus sign means that you can see very deep costophrenic angle compared to the right one, and this is a good sign for indicating the presence of pneumothorax on the left side. But here you can see big pneumothorax with underlying subtotal lung collapse. There is the depression of the diaphragm and somewhat shift of the mediastinal to the opposite side. And a small proportion of pneumothorax, as I have mentioned before, will enlarge to result in mediastinal shift and tension pneumothorax, especially in ventilated patients. And this is a tension pneumothorax with depression of the diaphragm, deep sulcus sign, compression of atelectasis of the lung, and contralateral shift of the mediastinum. This patient, according to the literature, is symptomless. It has a right-sided pneumothorax, as you can see. The patient came for a checkup 1 week after removal of a chest tube due to right-sided pneumothorax, and he denied any symptoms. Then you can see a big size pneumothorax and even with minor symptoms. And another tension pneumothorax with somewhat collapse or atelectasis of the right lung and shift of the mediastinum towards the left side and some depression and deep sulcus sign. Then in this patient, you got extensive air in the chest wall, which is known as subcutaneous emphysema or surgical emphysema, and you got tracking of air into the soft tissues of the neck, which, in my opinion, is one of the good signs to judge the presence of pneumomediastinum. This patient had a cuff fit, and it developed after that these extensive areas of surgical emphysema and pneumomediastinum. One of the best signs for pneumomediastinum is to see what's known as the continuous diaphragm sign. And you can see that the diaphragm, you can follow the contour of the diaphragm along its whole course. Then the causes of pneumomediastinum in an ICU patient include the spontaneous cause and injury to the lung by any of the devices, extensive or excessive vomiting, ventilators, and chronic obstructive pulmonary airway disease, forcible cough, as you can see in the previously mentioned shown patient. Then the continuous diaphragm sign is one of the radiographic signs of pneumomediastinum. Also, the presence of air in the soft tissues of the neck as well as subcutaneous will help in diagnosis. Then, pneumomediastinum should be differentiated from pneumopericardium since pneumopericardium cannot extend beyond the aortic contour, but pneumomediastinum can extend even into the neck, and also you can appreciate the continuous diaphragm sign. And here you can see one of the best signs is the presence of air tracking in the soft tissues of the neck. Also, you can appreciate the surgical emphysema, and you see also the continuous diaphragm sign. Another case where you can easily appreciate the continuous diaphragm sign, and you can see the air in the neck as well as at the shoulder region. Sometimes you may be able to have a CT scan, and it will clearly identify air within the mediastinum. And there are too many signs that have been mentioned in the book to diagnose pneumomediastinum, but I think that the best two signs are the presence of air tracking in the neck and also the presence of continuous diaphragm sign. But this is one of the signs mentioned in the literature, which is the double bronchial wall sign, because of the presence of air outside the bronchus and air inside the bronchus. And this 19 years old male has traumatized, and the radiograph showed suspicious right pulmonary contusion due to the opacity in the right lower lung lobe. But if you look carefully, you can see the continuous diaphragm sign, which is an indication of pneumomediastinum. Then we came to the pleural lesions, and one of the most common pleural lesions seen in ICU patients is the effusion. And the effusion in ICU patient is, and the incidence is about 62%, and 40% of the effusions are detected at admission, and 90% of effusions are of the small size. Causes of effusion include exudative, like parapneumonic effusion, malignancy, emphysema, and pulmonary embolism, or transudative due to heart failure, volume overload, hypoalbuminemia, and uremia. In my opinion, the best way for detection of pulmonary and pleural abnormalities in the ICU patient is ultrasound, provided that you have a good operator. An ultrasound can see all the pleural pathology, can see most of the lung parenchymal lesions, and this is a good example how to look at the pleural effusion. Many times the effusion is small and you cannot see in the plain film in the frontal view. You may have the lateral view, which will detect a smaller size pneumothorax, and you may also do the decubitus position to see that the fluid is tracking through the pleural space. But if you use ultrasound, you are able to see very small pleural effusions without the need for to reposition the patient. Also, it must be noted that sudden large pleural effusion will suggest an underlying hemorrhage, and this is very important in ICU patients. There are two examples of how the effusion is clearly demonstrated by ultrasound. and you can measure the size of the effusion, and you can roughly estimate its volume as well. This patient had mild bilateral pleural effusion, which is more evident on the left side, showing the classic appearance, which is known as the meniscus sign, diagnostic of the pleural effusion. You can see also the central venous line in an accurate position. This patient had a breast cancer, and you can see right evidence of right mastectomy. She developed pleural effusion, and she is receiving chemotherapy. Then clinically, it was suggested that this effusion should be malignant. Ultrasound-guided aspiration cytology confirmed that the effusion is malignant. This patient with amyloidosis had recurrent pleural effusion on the right side, and they tried to do talc pleurodesis, but the effusion recurred after that. Then, and the last follow-up done after 6 months of placement of a chest tube showed that no recurrence of the pleural effusion that was interpreted as spontaneous pleurodesis, and the drain was removed. And here you can see a markedly tilted chest radiograph, which is considered usual in the ICU patients. This patient had severe pancreatitis, and the X-ray was requested to assess the position of the nasogastric tube and the changes in air entry on the right side. But here you can see some veiling and opacity in the left lower lobe with obliteration of the costophrenic angle, suggesting the presence of pleural effusion. Then a CT scan showed the presence of pleural effusion and underlying consolidation. Also, pneumonia will result in the development of effusion, which is known as parapneumonic effusion, as you can see in this particular case with obliteration of the costophrenic angle. Then we came to three issues in the mediastinum, which are the pulmonary embolism, the superior vena cava obstruction, and the cardiac tamponade. The pulmonary embolism is one of the well-known events that can be identified in the ICU patient, and you know that pulmonary embolism can be completely silent without the development of significant symptoms. And in symptomatizing patients, the symptoms are not usually specific, like dyspnea, tachycardia, hemoptysis, and so on. There are a lot of risk factors that may predispose to the development of pulmonary embolism, like the previous embolic event and the immobilization, trauma surgery, shock, obesity, pregnancy, polycythemia vera, and antithrombin 3 deficiency. Then the chest X-ray is of poor sensitivity, and the signs seen on a chest X-ray are not specific. They include the presence of some atelectasis, elevation of the diaphragm, and the enlargement of the main pulmonary artery. And sometimes you got peripheral oligemia beyond the point of occlusion. Multifocal consolidation within 24 hours following the embolic episode may be seen in the lung parenchyma, and also you got a pleural-based opacity called the Hampton hump may be also noted. Pleural effusions are also seen in patients with pulmonary embolism in about 50% of the cases. Then the Bellow's sign indicates that there is a significant distension of the right main pulmonary artery proximal to the site of the occlusion. This sign is of low sensitivity, and its specificity is not known. Then also you got the Hampton hump sign, which is the pleural-based triangular opacity, the base towards the pleura, the apex towards the mediastinum. This is not also specific for a pulmonary infarct. But here you can see also what's known as the Hampton-Hump sign and the obliteration of the costophrenic angles by pleural effusion. The CT scan showed the consolidated area or the infarcted area in the lung, and you can see some filling defects in the pulmonary arteries denoting bilateral pulmonary embolism by CT scan, which is considered the most sensitive way to see pulmonary embolism. And here you see basal atelectasis with some elevation of the diaphragm. The CT angiogram showed an embolus within the lower lobe pulmonary artery branch. And this patient with pleuritic pain and mild breathlessness, you can see an almost clear chest radiograph apart from this veiling near the costophrenic angle on the right side. But here you can see by CT scan bilateral filling defects in the pulmonary arteries denoting emboli, and you see a pulmonary infarction in the right lung. Then we came to the superior vena cava obstruction. There are a lot of cases, in particular malignancy, which is responsible for about 90% of the cases. And in ICU patients, the central venous catheters, they are one of the major factors contributing to IV superior vena cava thrombosis. Also, the pacemaker wires and many other causes. This video, I think, will show.
You got a patient in bed C3. It is not such a young patient. They are short of breath, have some chest pain, and they describe this headache. It just feels like their head is going to pop right off. Have you ever had this presentation before? You go onto your physical exam, and one thing that really stands out is, man oh man, those are some distended jugular veins. So you quickly fight the urge to throw a central venous catheter in, and you start your diagnostics, beginning with a point-of-care ultrasound. And this is what you see. Let's pause for a second here just to geek out about how amazing this image is. Do you know what you're looking at? Well, the top anechoic thing is the large, distended, internal jugular vein, and right below it you see a small but pulsatile carotid artery. And to me, it looked like there were waves just crashing against something and then backing up into the internal jugular vein. And that is in fact what is going on. This person had superior vena cava syndrome from a large tumor in their chest. Now, SVC syndrome can have multiple etiologies, but basically it's either from external compression or some internal blockage, mostly a clot. That external compression is almost always a mass, and that can be malignant or benign. You're hoping that's benign, but just like my pathology professor used to say, the good news is benign, the bad news, it killed you.
Okay, then in order to diagnose superior vena cava obstruction, it's an easy way by CT and even by ultrasound, as you can see. This is the superior vena cava, which is obliterated by a clot that is not enhancing, and the wall is only enhancing. And sometimes you see the causative lesion, like a tumor mass, compressing the superior vena cava or mediastinal lymphadenopathy. And many times you are able to see collateral vessels along the chest wall, and this arrow points to the thrombosed superior vena cava. This patient with iatrogenic chronic superior vena cava obstruction secondary to repeated central venous catheter placement, and they see that the superior vena cava is totally obliterated, and there are too many collaterals in the chest wall as well as in the mediastinum. One of the ways to treat superior vena cava syndrome is to place a stent in order to maintain patency of the superior vena cava, as you can see here. Last issue is the cardiac tamponade, and the cardiac tamponade means accumulation of fluid like effusion, pus, or blood, or gas, even gas, or neoplastic tissue within the pericardial cavity, hindering the contractility of the heart. The pericardial effusion, this is very important, can be very large, but it does not necessarily impair the cardiac function. The big triad, which is used to diagnose cardiac tamponade, consists of muffled heart sounds, hypotension, and jugular vein distension. The triad strongly suggests tamponade, but is present in a minority of patients. In this patient with breathlessness on exertion and chest pain, the chest X-ray showed evident enlargement of the cardiac shadow, suggestive of the presence of pericardial effusion. Then there are very important signs that can be seen on echocardiogram to show for the diagnosis of cardiac tamponade, and that's why I always mention that the ultrasound is one of the major diagnostic tools that can be used in the ICU unit. So you know that ultrasound is a portable machine that can go to the patient in the ICU. It does not use ionizing radiation and needs no preparation, and also have the Doppler facility, and there is relatively of low cost compared to the other imaging modalities like CT and MRI. And here you can see the presence of significant amount of pericardial effusion, and also you can see the effect of this effusion on the cardiac contractility. Particularly, you put too much attention for the right ventricle, which is almost totally collapsed while the cardiac is functioning, the heart is functioning. Then this is one of the signs. In here you can see almost total right ventricular collapse with on the left side you see some distension of the left atrium, and also look carefully for the right ventricle, how it cannot expand in a similar way to the left ventricle. And here you can see the this is one of the best diagnostic criteria for cardiac tamponade. Then echocardiography can also give an information about the size and the location of the effusion, the presence of loculated effusion if you would like to drain it, and the evidence of hemodynamic compromise, which include right atrial collapse, right ventricular diastolic collapse, respiratory inflow variation across the mitral and the tricuspid valve, and also assessment of the inferior vena cava, which is usually dilated and unreactive. And the CT scan can also show some signs that are helpful to diagnose cardiac tamponade, including information about the precardial fluid, whether it is blood or it is pus or it is just transudate. Then CT findings are non-specific but include, number one, distension of the superior vena cava and inferior vena cava, distension of the hepatic and renal veins, periportal edema of the, and you see these hypodensities around the portal branches. This is periportal edema, a reflux of contrast into the IVC during the arterial phase, compression of the coronary sinus, angulation of the interventricular septum, the pericardial thickening, collapse of the right ventricle, and aortic blood contrast level. And you see here, this is a case of cardiac tamponade due to large pericardial fluid collection, and this is what's known as the deviation of the interventricular septum to the left side, which is considered one of the signs of cardiac tamponade. Also, you can see the distension of the inferior vena cava and the right renal vein, and you can see also the hypodensities around the portal venous radicals, denoting periportal edema. And here an example of cardiac tamponade, big pericardial collection, and you can see the reflux of the contrast material within the inferior vena cava. You can see also bilateral pleural effusion more on the right side. This patient had a big or extensive pericardial fluid, but with no signs of cardiac tamponade. This is an immunocompetent patient with untreated hypothyroidism, admitted with massive pericardial effusion. She had no signs, either clinical or echocardiographic evidence of cardiac tamponade. That the culture of the pericardial fluid showed salmonella organism. In the hypothyroidism is a known but rare cause of pericardial effusion. Why the patient is not having symptoms of cardiac tamponade due to the insidious onset and the slow fluid accumulation within the pericardium. Then if air is accumulated in the pericardium, this is known as tension, and it may result in cardiac tamponade as well. You may be also able to notice the presence of bilateral pneumothorax. And this is another case of pneumopericardium. Remember that air cannot extend beyond the level of the aorta in cases of pneumopericardium. And in cases of pneumomediastinum, you can see air tracking in the neck, and also you can see the continuous diaphragm sign. This is what is known as hydropneumopericardium, which is almost similar to hydropneumothorax, and you got massive pericardial collection and as well as air fluid, and the echocardiography showed massive pericardial effusion causing more than 50% respiratory variation of the mitral inflow, which is diagnostic of cardiac tamponade, and this is the CT scan showing the same finding. Thank you very much. Walhamdulillahi Rabbil Alameen.